Sosyal anksiyete bozukluğunu nasıl tedavi ediyoruz ilaçlarla? Ne zaman başlıyoruz bu tedaviye? Klinik uygulamalarımız nasıl? Bu konuyla ilgili araştırmalar ne söylüyor? Ben biraz böyle çocuklarda anksiyete bozukluklarına da şöyle bir atıfta bulunayım. Çünkü gelişimi biliyorsunuz bu bizim çocuk ergen psikiyatrisinde çok takipte çok hızlı görüyoruz değil mi? 0-18 yaşın her bir dönemi birbirinden farklı, biraz erişkin psikiyatrisinden değişik. Her yaşın gelişimsel özelliği var ve bizim gelişimsel korkular dediğimiz, değil mi? Kaygı olarak da ifade ettiğimiz ama bozukluk grubuna sokmadığımız özellikleri var çocukların gelişim sırasında. Bir şeyler onları kaygılandırıyor. Mesela çok küçük çocuklar için bir yüksek ses bir kaygı nedeni olabiliyor. Çocuk daha büyüdükçe, bilişsel yapı geliştikçe öngöremediği şeylerden kaygı duymaya başlıyor. Nurhida'nın ifade ettiği gibi bilişsel düzey, üst biliş geliştikçe daha sosyal, soyut konularla ilgili
topics with social and abstract topics. But while we are talking about the anxiety, we need to know the structure of the child, and we need to know about the anxiety of the parents. In which environment are they living? All of those things are important, and they are playing a role in the social anxiety. So the social anxiety disorder tends to develop during adolescence at a median age of 13 to 40 years. And during adolescence has a prevalence rate of 10 and 15%. And if it is left untreated, it became very notorious and also carries significant social burden uh, in a friendship and romantic relationship. Also, yeah, it is associated with impairments in the educational attainment, occupational functioning, and overall in the quality of the life, and also in the rejection from the school. We have a lot of adolescents who don't want to go to school, and their parents want them actually to go to school. But there may be different issues, but SAD is one of the most prominent. And the early treatment may prevent and alter the course of developing this disorder. It's like protective medicines, and also it is preparing the children with fewer psychopathologies. So early treatment may prevent and may alter the course of developing depression. And most of the time, I think that it is skipped. And some of the times, in the society, the kids are perceived like in a good way if they are calm, and sometimes this is something skipped, especially with the girl with the girls. During my assistance, I was working on a set, and I had more time to work on that. And I can tell you that the group therapies are very useful, especially for children with social disruptions in order to develop a sense of belonging. And with the individual relation, it's easier, but it's harder for them to engage in the peer relations. So, looking at the treatment, we have cognitive behavioral therapy, and there are a lot of cases in which only the CBT is enough, but and especially for obsessive compulsive disorder, OCD, and we have uh, SSRI, and they are safe and efficacious for treating them. This is why I put the SSRI on the first rank. In our clinical practice, I think that it is very important. Maybe at the end we can share that. So the SSRI are important for us, and we have good responses both in terms of clinical properties and there are a lot of studies. Here we have a book published in 2024, and it is about the frequency of usage of SSRIs. Of course, there are some different tables. Here we have the SOC. This, for example, we have escitalopram. Escitalopram is more predominant. And also for the kids with additional issues with autistic spectrum and social anxiety. Uh, I'm using escitalopram. And sometimes in the autistic group, we need to be attentive with the dosage. We have citalopram and also escitalopram, fluoxetine, and fluvoxamine, paroxetine, and those are the main indications. And also there are a lot of studies on sertraline too. We are using it. We have fluoxetine, and it's well tolerated, and it eases the symptoms. It starts with the lower doses of 10 milligrams in the first weeks. And also, there are a lot of trials on paroxetine, but I can't say that it is widely used in our clinical practice. Do we have uh, children psychiatrists? No. Maybe we have results and we add the cognitive behavior. The families are happy. But with hospitalized service patients, maybe they are using that. We are not using it a lot. I started to use that with some of my patients. Sometimes we need to use that to see that it is bad. And I saw a lot of withdrawal and tremor. And if you don't give it for 1 day to a kid, they can have a panic attack, and the uprising is very high when you go from 10 to 20. They became very dynamic, and I'm not offering this for the kids, and maybe the suicidal tendencies increase. And I think that the adults are using paroxetine too. there are a lot of more trials with paroxysm for the adults. And also the FDA approval is more important with sertraline, with fluvoxamine. And it is important to know the side effects and to explain those side effects to the family. And the sets uh, sometimes may be shown with physical symptoms, because the anxiety can have physical symptoms and it needs to be distinguished. But we have just side effects, weight gain and sweating, dry mouth, headache, irritability, insomnia, fatigue, restlessness, and the increased risk of self-injury. And the potentially more serious side effects uh, may include the syndrome of serotonin, the hypomania, mania, and seizures, and we need to be aware of that. Of course, when we look at the profit and risk, of course, the profits are better. It is well tolerated, but sometimes it is not possible for us to continue. And also the eliminating life, it's very important. And also we have the suicidal risks, and there is a warning of the FDI on that. And we need to have a good cooperation on the family. And sometimes I see that the families are taking the medications by themselves. But usually I want the family to follow up that. So with the long-term treatment, we have successful results, but our families are not patient, and they can behave more impulsive. And there are a lot of families who are afraid of the medicines. The basic difficulty is to inform the family. Sometimes they don't want to start, and even if they can start, they don't want to continue that. So if we want to cut down the burden, we have long-term treatments. So if we don't have good results with SSRIs, uh, we have SNRIs according to the treatment protocols. We know atomoxetine here, it's used for the ADHD and may reduce comorbid anxiety symptoms. Of course, we need to monitor the kids for mania and Sordon syndrome. Venlafaxine and duloxetine, I'm not clinically using that. I'm not prefer that, and they don't have the indication for the kids. But of course, there are studies for this group. But it's more indicated for the adults, and the kids are not the first options, and they have a lot of side effects. But of course, all of those are potent drugs, and for the adult psychiatry, they may be preferred. But as I said, they are not the first choice. So the benzos, Benzos, they are more commonly used to calm the procedural anxiety in children and adolescents. And we are using for the short-term treatment. But however, we are not preferring them for long-term treatments. You can see the indication in here with clonazepam, alprazolam, and lorazepam. Here we have the risks. Let me skip that. And we have the tricyclics. When I was an assistant, we used the tricyclic a lot because they were indicated for ADHD. It was harder for us to have those. And also uh, Gazi University worked a lot in order for us to obtain those medications. And back then, we used the tricyclics for separation anxiety, for ADHD. And in the multiple of the cases, they were interrelated. But we are not preferring tricycling. Preferring tricycling very much in the children and adolescents. But we used to use them in different diagnostic groups. And of course, uh, we are using the clomipramine in the OCD. Here we have the cardiac side effects, and also we have buspirone. It's not approved for children by the FDA, but it is indicated for OCD, for GAD, and for SOAK. And also we have effects in child psychiatric inpatients age 5 12 who exhibited symptoms of anxiety and moderate aggression. And we saw that it was effective. Here you can see all of them, the SSRI, the tricyclic, and also with mirtazapine. We have some studies on mirtazapine. It has a co-effect. We have the beta blockers and antihistaminics. The main indication is anxiety. So if we have symptoms of anxiety, we can use them. We can use the hydroxyzine, but because we have now more effective treatments, we are using that. And also propanolone is used in small doses, especially in my clinical practice. Uh, we have a lot of tablets within this medication, and we are giving them in very small doses. And we need to warn the family, and we want the family to be aware about that, because if there is a suicidal tendency, they need to take care of that. So the antipsychotics are not used for that. We are using SSRI. But because there are a lot of other issues with depression, autism, and other issues, So we are using them in combination with antipsychotics in self-harm behavioral patterns. We have other potential compounds. We don't have clinical evidence on that. We have candospirone is a partial agonist of the serotonin 1A receptor with anxiolytic properties, and it is effective on the adolescents. And also there is another study with guanfacine. This also is used to treat anxiety disorders in pediatric populations. And again, we need to follow up very well. And at the end of the treatment, out of the pediatric anxiety assessment scores, better scores, we need to be uh, attentive with propanolol and hydroxyzine. There is insufficient evidence to support the use of propanolol in the treatment of anxiety disorder. Maybe is limited to specific situation in anxiety symptoms. So it's important to do a good monitoring, and we should document the baseline weight, height, the vital signs, and to monitor those over time. And also the laboratory symptoms are very important. There are some values that we are looking for before the treatment. And if there is a family history, if there is a cardiac issues, we will ask for the HC and alcohol. And children with anxiety disorders may have somatic symptoms that may be confused with adverse medication effects. And for all the medication, the treatment should be initiated at a low dosage for the first 7 days, with the dosage slowly increased over subsequent weeks, depending on the child's clinical response. And instead of going with the medications alone, we'll need psychotherapeutic approaches. Psychotherapy have clearly demonstrated that lead to a significant reduction in anxiety symptoms in children. And the families, they need to be informed, and sometimes the approaches of the parent may be very challenging, very stigmatic. We have the kid with anxiety, and the parents are always pushing the kids, and they are giving him or her the message that they are not doing well. Especially, we need to deal with that, and we need to offer consultation to the parents too. And of course, this is related to the genetical structure too, and they want a lot of things to be changed. And especially when it comes to the kids that have issue in the social arena. Sometimes the kid is dealing with their own anxiety and with the anxiety of the parents. Medication is often considered for treating disorders, but the combination treatment, both the pharmacological treatment and the psychotherapy are effective, but sometimes the access to cognitive therapy is restricted, and this is why the medication is often considered. You know this algorithm. We have mild or moderate or severe, and we started with psychotherapy and SSRI, And according to the response, if we have response, we are increasing the dose of SSRI, or we are switching to SNRI, and we are reevaluate the signs, the comorbidities.
düşünmek lazım. Burada da yine benzer şeyler işte
Here we have similar
SSRI
to
tedavisinden sonra
after
yeniden
two unsuccessful two SSRI trials, we are reevaluating or consulting, and if there is OCD, we are using clomipramine and or venlafaxine, and we can think of benzos as the last stage. Here again, a study on mirtazapine. Also, there are effects of insomnia and appetite. And this is why we may prefer actually to use this type of medication. And we have the new agents like the gabapentin, the new anti-epileptic, and they can be also used in the anxiety disorders. We can see that they are included in the trials. I don't have any personal experience with the sets, but if also the accumulated evidence indicates that the cannabidiol may be also effective and indicated the reducing in the anxiety symptoms and also in phobias. As a conclusion, we need a very good assessment and evaluation. We need a distinctive diagnosis and prognosis, and after that, we need to support the pharmacological usage, pharmacological application with the psychotherapy. Thank you very much for listening to me.